Good afternoon. Glad to see so many here, and the public is so present. Wow. I'd like to call the meeting of the Health and Human Services to order on July 17th at 5 p.m. at the County Government Center, room 1284. Call to order, please.
Sean Anderson. Mike Barkalow.
Present.
Kathleen Findley.
Present.
Kathy Leaf.
Present.
Lisa Lynn.
Present. Present.
Dave Osnes.
Present.
Julie Smith.
Present.
Greg Telejohn.
Present. There were minutes from the previous meeting, June 19th, in the board packet. If there's no other discussion on them, they'll be approved as presented. Is there any questions or discussion on the minutes? Hearing none, they'll be approved as presented. Public comment. Any public comment? No. No public comment tonight. Business, Health and Human Services Financial Report for June 2024.
So the financials through June of 2024 are included in the packet. When you look at the tax levy, we're at 50%. That's halfway through the year. That's allocated at 1/12 each month. For 2023, we are just finishing up the audit. We will have audit entries that are going to be posted back to 2023. For the most part, all of the expenses were finalized, but we do have revenues that we received in 2024 that are currently showing in 2024 revenue that will get moved back to 2023 through the audit journal entries. Other than that, our federal payments, especially if you look at that top one, that other federal payment, those are the ARPA transfers that get made, so those just get made quarterly. We have not made one for the second quarter yet, so that's why that one looks so, we're only at 42 or 84%. But that'll be matching the expenses that have been recorded. Couple other things to point out if we look down to page 9. Just some of the red numbers you see, a lot of these items where we're significantly over, or it looks like we're over budget, those were grants and expenses that came after we had budgeted. So the revenues, we have revenues to offset those expenses. There was a lot of training that came up, a QTT grant, and our state opioid response that allowed us to do some additional training for the behavioral health staff. So those were included, we'll see those expenses, but we do have grant money to offset those. Are there any questions on the Health and Human Services? Okay, then I'm going to scroll down to the nursing home. Page 23. One of the changes that happened this year with the nursing home is the supplemental money that we had budgeted, and that was under this like 46910 other public services. The state is no longer going to pay us supplemental funds. What they're going to do is adjust the Medicaid rate and embed that into the rate. So the $400,000 that we have budgeted this year, we will not get. Right now, the Medicaid auditor is reviewing our rates that will be effective July of this year. So once we get those rates, that's where we'll see that supplemental money coming in then. Otherwise, the nursing home itself, their census has been steady around 37, 38. When you look at their revenue, they're almost $1 million higher this year than they were last year at this same time. So when you look at the next page, on page 25, right now we're showing 758,000 positive balance. There is no depreciation recorded yet. And as Ken's mentioned, other times, they've been covering operating expenses, but as of right now, they would be covering some of that depreciation as well. So any questions on the healthcare campus?
And I don't know if you know the answer, but
the additional revenue, is it just additional census, or is it just what type of services maybe are we doing that are bringing in that revenue? Is it more rehab or?
No, so when they calculate the Medicaid rate, they have a whole bunch of different areas where they set fees for that. So there's a direct service, there's social services, there's nursing care. So all of those different areas feed into it, and then they come up with a base rate, but then they do this PDPM, so based on the MDS that's completed by the nursing staff and the level of care that people get, every single resident actually gets a different Medicaid reimbursement now, so that's since last year.
So that's good. Really good.
Yeah, I liked seeing it just one lump sum payment. Now it'll be part of our Medicaid rate, so it's not as easy to forecast what it will be. But no, overall, it's good for the nursing home.
Any other questions? Okay, thank you.
You're welcome.
Review of Aging and Disabilities Resource Center Services and Programs.
Mr. Chair, I asked Kristen Newton, our ADRC administrator, to come and talk to us today, partially because of the increasing demands we're seeing among the aging population in our county. And I thought it would be a good time maybe to have her explain all of the things that they do and some of the challenges and successes they've had in recent times with trying to build efficiency into what they do. So I'll turn it over to Kristen.
Hi, everybody. So as Bob said, I'm Kristen Newton. I'm the administrator of the ADRC. One second here, I just need to get, my voice goes nowhere, so you're gonna want me closer to the mic. So I've been with the county for a pretty long time. This is my 22nd year, actually, but I've only been in the ADRC for about 2.5 years. So I'm gonna do my best to go through all of our programs and give you a little bit of insight on what we do in the ADRC. So this is our mission statement. It's in actually our blue books, and we distribute this and kind of try to follow this, obviously, in our day-to-day operations. I've got some handouts for you guys, too, that I'll share with you before we leave today. But basically, the ADRC works to empower individuals to make informed decisions about long-term care, thus assisting in conserving resources, remaining independent and self-sufficient, and delaying the need for potentially expensive long-term care services. This is a list of our key services that we provide in the ADRC. I won't read through them, but that's what we do. Basically, our biggest program areas are right there. And again, all this information is in these blue books that I'll share with you before we go today. This slide talks a little bit about who we serve in the ADRC. So we serve basically any adult living in Wisconsin in our county who needs information about maintaining independence, long-term care options, disability services, mental health care, Social Security, Medicare benefit programs, and lots more than that, actually. We have required target groups that people have to meet in order to receive services in the ADRC, and that's basically anyone who's the age of 60 or older. So there's no other requirement. As long as you meet that condition of being 60 and older, you meet under our aging guidelines for services. Adults with intellectual or developmental disabilities, anyone over the age of 18 for that criteria, and adults with physical disabilities, same, anyone over the age of 18 for that. We make those full range of services available to the individuals who meet one of those required target groups, but we also serve individuals who have substance use disorders and mental health challenges. They just don't always meet certain programming if they're just diagnosed with a mental health concern. That will be something we would refer out to, such as behavioral health or another program within the county. But a lot of people have both concerns going on at the same time. Our team serves a lot of individuals who are young adults transitioning into adulthood. Maybe they're currently working with our children's services program who are receiving some type of service for a disability in the youth system, and we help them transition into the adult system. We also work with a lot of family members and caregivers as well. So if you can move it on. I'm on slide 5. Sorry, is it not catching? It's not keeping up? That's pure honesty. ADRCs provide the above related services there. I just kind of explained that a little bit with regards to mental health and substance use treatment. So like I said, we serve a lot of people who deal with challenges like that on the day-to-day, but if they are just diagnosed with a substance use disorder, they oftentimes don't meet the criteria for some of our programs. Just a quick note, our disability benefit specialist is a good resource for individuals living with just a substance use disorder or a mental health concern. They help get them connected with disability services, or they'll help them with an application for disability. We also do a lot of information and referrals, so not only just to our internal partners in human services, but also to external partners. Things that we can assist with include maintaining independence, choices for long-term care, related services, Medicare benefits, other benefits, Social Security benefits, support services and resources throughout the community. And also, like I said before, just prevents the need for costly long-term care services. Within the ADRC, it's really a team of specialists, so everybody is really specialized in their program area, which is a great service that we have all these people who are considered experts, but it gets challenging when there's a need for like coverage or if staff are out, because you can't just swap between divisions. Everyone is really just connected to that program area. This slide here moves on to the history of the ADRC. So it talks a little bit about how in 2007, the St. Croix County Board of Supervisors passed a resolution authorizing the county to apply and operate an ADRC. So the ADRC went into operation then in 2008. That's when we combined from being the long-term care unit within Human Services and then the Department on Aging. We merged into one unit at that time. Throughout the state of Wisconsin, each county has some type of ADRC coverage. They may not have their own ADRC like we do here. They may be more of a regional model, but each county is represented in some capacity. And so every county has gone into inception at different time periods throughout Wisconsin. And we went in obviously in 2008, like it says there. Talks a little bit about moving to the health center, or the services center in New Richmond in 2014. And then another important piece is that the ADRC is funded by state general purpose revenue, claiming of Medicaid federal dollars, state and federal grants, the Older Americans Act, and there's some county levy dollars that go into our programs as well, which you all hear about often. In 2023, it's important to note that every dollar invested in Wisconsin's ADRCs led to a savings of $3.88. And I'll talk a little bit about it at the end too, but there's some really good data out there on the impact of ADRCs and what that actually does to save tax dollars. And I also have a handout for you on that too. So a few fun facts about the ADRC. They're the only provider of local, unbiased decision support. ADRCs have local offices in every county throughout Wisconsin, like I shared. The mission is to help people prevent or prolong the need for costly services. There's no income or asset requirement to use the ADRC services. Certainly there's certain programs that do have certain requirements that way, but there is no income or asset limitation that prevents anyone from accessing the ADRC. Like I said, it's just anybody who's over the age of 60 or anyone who's an adult living with a disability. Phone calls made to the ADRC are answered by a live person, and individuals are able to meet face-to-face with ADRC professionals in their home, in the office, or anywhere else in the community. Next slide talks about our organizational structure. It's probably kind of hard to read there, but it does a little drop down for each program area and the number of staff that we have in each program area. All of the boxes that are listed there are considered our aging programs, so those have different funding and different rules and different things that they offer through the aging side of the ADRC. And the others are on technically the ADRC side, which also has its own set of rules and funding. I'm really proud to share with you that many of our staff have been employed with St. Croix County since the inception of the ADRC and even longer than that. I did the math today and we have over 217 years of experience just in our 18 staff members within the office of the ADRC at the office. We have some other drivers and other program team members as well, but I didn't count them, but the ones that work in the primary office there have that much time employed by St. Croix County, and I think that's pretty cool. Moving on to the next slide, it talks about just kind of our big, back to our key services, so the information and assistance, the options counselors. We call these team members the ADRC specialists. This is really our funnel into the ADRC. So when an individual calls and is looking for services, looking for resources, they get funneled into this area. And we have a team of 4 staff who operate this program essentially. So they rotate intake days, so they cover all the calls and referrals and walk-ins into our building Monday through Friday, 8 to 4:30. So there's always an options counselor there. One point that I wanted to make sure that I mentioned is that I list here that they're all certified social workers. This actually changed because we were lucky enough to get a 4th position this year, and so she actually isn't certified as a Wisconsin social worker, but she worked as a social worker in another country for many years, so she has a lot of experience kind of working as a social worker. A lot of times this division is really the first point of contact for the ADRC. Like I said, it just really funnels the people there. And this area has been it's become pretty taxing. We've seen a lot of increase in service demand especially since COVID. The last couple of years have been pretty busy. And I'll talk about it a little bit at the end too, but even just with the numbers, and like I said, I'll share a little bit more on the data at the end, but just yesterday alone, they took 7 new referrals, and that's, sometimes we get 7 in a week, and so they're really facing a lot of challenges just trying to manage the demand, and it just causes us to think about things more efficiently to work, because we can't turn people away and we can't project the demand for the service, obviously. In 2023, this division had 4,020 calls, which was a 41% increase just from the year before. So they're pretty busy. Moving on to the next division is our disability benefits specialists. So we have 2 of them. So they serve individuals who are age 18 to 59 who have some type of disability, and they help them apply for disability benefits. They also help with appeals and work real closely with Social Security. This program is supervised through the Disability Rights Wisconsin. They have a program attorney that oversees this program. There's 2 of them, and they manage about 200 cases, open cases at a time. So individuals who are applying for disability get kind of set up in this queue that they're managing to make sure that all of their information is ready to go, and they're checking in to make sure everything is coming to fruition, essentially. And there's been a lot of delays with COVID, and with Social Security, the Disability Determination Bureau has been really backed up, and now that's all starting to come forward. So they're getting a lot more cases that are coming to fruition, which is just really adding to the workload and their demands. The last time I updated some of these notes was last year, and they had 150 open cases at a time, and now they have about 200. And last year, their supervising attorney gave me a little grief saying they had too many cases open, so we'll see what she says this year when they have 200 cases open. Next program area is the Elder Benefits Specialist Program. So this is similar to the Disability Benefits Specialist Program, whereas these individuals serve anyone age 60 and over in the world of benefits. So they provide a little bit more specialized service for individuals who need help with their Medicare Part D, annual enrollment, those types of updates, helps with Social Security, and just some of those things that are just really complicated and hard to navigate with other programs, medical assistance, and there's just a lot of rules, a lot of red tape, and they really help navigate that and help advocate for individuals in this demographic. A couple years ago, we really changed how we were doing business in this area. They see a lot of people one-on-one in the office now. They schedule a lot of appointments. They served, in 2023, there's the 2 staff between the annual enrollment period of October, the middle of October through the first week of December, they met with 308 people in the office. So they just scheduled appointments, and as many as they could fit in just so that they could help people get their Medicare Part D stuff covered. That was an increase of 140%. So it's pretty cool. They weren't able to turn anyone away. Nobody was denied the opportunity to meet with someone. And it's nice to see the team that just really works hard to serve the people without putting parameters around it, despite the challenge of trying to do that. The next program is our nutrition program. So this is one of our aging services. So individuals over the age of 60 or ages 60 and over are eligible to go to one of our nutrition sites and partake in the social activities and receive a hot, nutritious meal. We refer to this as congregate dining with individuals, and there's home-delivered meals also offered for individuals who have a high nutritional risk, who are vulnerable, who aren't able to get out and make meals on their own. We have a team of a lot of volunteers that actually provide meals to those individuals in our county. We have an outreach coordinator in the home delivered meal program who goes out and meets with all of the recipients to assess to make sure that they still meet the criteria and still need the services, still need the meals. Last year we served about 50,000 meals between congregate and home delivered combined. So there's 9 different sites. 2 of them are restaurant models. We're really proud to talk about that transition. That was more of a progressive type movement. It was pretty innovative. It's person-centered. It provides a lot of opportunity for choice and for people to not feel stigmatized by going to the senior center to eat lunch. They can just go to a restaurant, have lunch, and participate in the social activities that are provided there. We have different aging programming rules that guide how we do our services, and so those restaurant models really check a lot of those boxes of things that we need to do to help people access nutrition and help reduce contact with other areas like adult protection and other, hospital admissions, things like that, because our food and nutrition is obviously even more important as we get older. The programming is also contributions based, so it's Older Americans Act money. We get some grant funding through the Older Americans Act, but it's really intended to be seed money. They're not able to provide enough money to support the whole entire program. It's an expensive program, but it's a really helpful, impactful program. And like I said, we really try to mitigate those costs with offering as many volunteers as we can to help get those meals out and check in on people. Sometimes that contact with the driver is really the only time someone's had contact with anyone in any given day. And so they provide a safety check, and they give them a little social opportunity to greet someone and say hi. And also they have a nutritious meal, so it's a really good service. A really important fact that that couldn't emphasize more is that 1 year of home delivered meals and the services that accompany that home delivered meal service roughly equates to the same cost of 1 day in a hospital setting or 10 days in a nursing home. So it's a really cost-effective way to help people maintain their independence, stay in their home, and meet their needs in a real, like I said, real cost-effective way. Moving on here. Okay, next program is our transportation services. So we receive a 8521, it's a state-funded grant through the Department of Transportation, and that grant amount is based on the number of older adults and people with disabilities living in your county. So we get a grant amount that we're able to utilize programming in 5 different project areas. So we have specialized site transportation in 8 of our communities throughout St. Croix County. You've maybe seen some of our vans or buses driving around that say ADRC on the side. We also partner with the River Falls Rideshare Taxi to offer supplements for individuals to get around that community at a cheaper rate, or to get to the senior center to have lunch. We also partner with New Freedom Volunteer, their transportation program through the Center for Independent Living. They are able to provide a volunteer if you need to get, if your age is 60 and over and you need to get from one community to another for an appointment or something, or even just an outing, that you can call the Center for Independent Living and schedule a volunteer driver. Hudson has a new program for their service, so we've been partnering with them too, so they're offering a rideshare taxi program as well. And then we also partner with New Richmond with their rideshare taxis, so we offer some supplemental funds to those programs so that individuals can access transportation at an affordable rate. And it shows there that we just charge $2 fare per round trip. So if you hop on one of our buses, it's just $2. One, you're going to Walmart, it's $1 to Walmart, and $1 to come back home, so it's pretty affordable. Next program is a dementia care specialist. So we have a program within the ADRC, so dementia care provides a lot of specialty services for individuals living with dementia. The dementia care specialist also does a lot of work in the community to make businesses and just the general public dementia friendly or dementia aware. This is a program of one staff. We have a new dementia care specialist. She just recently transitioned. She was a former St. Croix County employee and has come back, so that's pretty exciting. We're really lucky to have her. Our previous DCS had just transitioned to another internal position within St. Croix County, so we're also lucky that she didn't leave because they're both great. So the DCS also she co-leads the St. Croix Valley Dementia Friendly Communities Coalition, so they do a lot of activities and events throughout the county in partnership with Pierce County just to make people aware and more dementia friendly. Some statistics: in 2020, there was about 120,000 people over the age of 65 in Wisconsin living with a diagnosis of dementia. In 2025, that number is estimated to be about 130,000. Rural communities are seeing a bigger increase, especially as our population is growing older. There's obviously a caregiver shortage. You've probably heard that. It's on the news often. There'll be more people with dementia, but the lack of staff to care for them in facilities, putting more demands on family members. It's a bad state of the times. I sound really depressed. All of my material sounds depressing, but we're doing good stuff just to help offset some of this stuff. So that kind of leads into caregiver support. So our caregiver support coordinator does a lot of work with our dementia care specialists. So the caregiver support coordinator obviously does a lot with the caregivers. She does a lot of work to meet one-on-one with families. She provides a lot of education, support groups. We also offer a program called Day Away, which is a social respite. It's an opportunity for a caregiver to bring someone living with a diagnosis of dementia to the social respite so that the caregiver can get a little bit of a break, go to an appointment, get some groceries, that sort of thing. These services are critical, and if people don't have options for these types of resources, they end up in other systems of care. They end up in the emergency department. They end up with law enforcement involved. They end up in adult protection, whatever it may be. It's really scary times for people living with dementia and with our caregiver shortage, and just as our population is aging and growing, there's fewer and fewer caregivers and more people living in an older generation. We received some funding through the Older Americans Act to operate some caregiver programs and caregiver opportunities. But interesting enough, the funding amounts have not changed since 1985. So you can just picture the number of hours that somebody in 1985 could receive in respite for that price. And now, fast forward however many years later, the same amount of money obviously doesn't go nearly as far as it went in 1985. So we're doing less with more demand as time goes on. Another interesting stat is that 1 in 7 current non-caregivers expect to become a caregiver. These are family members. They expect to become a caregiver in the next 2 years. And by 2050 in Wisconsin, there'll be fewer than 3 family caregivers available for each family member over the age of 80. So that just speaks to how the demographic is changing, and it's concerning for sure. So moving on, what's the next one? Oh, so we have some healthy aging classes. We receive some grant funds for these programs as well, and we offer these throughout the county at different times. Our caregiver support coordinator helps with this, and we also partner with some other local agencies that help run these programs. They're evidence-based. Anyone can sign up. They're great classes. Last year in 2023, we were awarded a grant called the Independent Living Supports Pilot. So it was a state grant with some ARPA monies that they received to run this program. And so it was kind of considered a long-term care light type program. So it's a bridge essentially for those individuals who need some help in maintaining their independence, but don't quite meet that threshold of needing publicly funded long-term care services. So the program, in theory, is a really great opportunity to help provide some short-term services, help kind of bridge the gap for individuals. There's a higher income limit, and it's a more liberal eligibility criteria, essentially. And then anyone who is eligible receives $7,200 to help bridge this, gap, basically, for independence. And the grant then runs out in March of 2025. So all those individuals who were enrolled in the program, the enrollment period has now ended as part of that timeline, but everyone enrolled will have until March of 2025 to spend those funds. There's been some challenges with it. The concept has really been great, but there's just been some challenges rolling out a pilot. I mean, you can imagine throughout the state, it's just been a little bit tricky getting that going, a lot of bumps. But all in all, it's been great for the people who have been able to be enrolled. We were lucky. We had 2 staff persons that worked with us in the ADRC and for St. Croix County. They both recently retired with about 30 years of county experience, and I was able to get them to come back on part-time and work this program. So they just kind of picked it up day one, and they were able to roll with it. So we were very fortunate because we didn't have to go through a hiring, recruiting process and onboarding and training and all these things. They were just really ready to go. So that was really helpful. But again, there's been some challenges with it. So just kind of a final slide. I know it's really hard to see from this distance, but the top line shows, the one that's in blue up there just speaks to the volume of referrals to the ADRC, just to our ADRC specialists, that intake team that I referenced early on. The timeline at the first spot there, it looks like it's from 2008. So that's when the ADRC went into motion. And obviously our data collection is a little bit different in 2008 than it is now, but we were working with about 500 people there with 3 staff. And here we're up to, over 4,000. So you can just see the growth, which is good. It's good we're getting out there. People are more aware of us, but the population's obviously growing too, and the demands are growing. So like I said, even since last year, that intake line has nearly doubled for individuals. Another line there, that the other 2 programs that I listed there, it's again hard to see, but one is the disability benefits specialist. I think that's the orange or the red, and then our elder benefits specialist is listed as more of a gray. And you can just see, some of this is obviously COVID related. We've had some staffing changes, so you can see where it's a little bit low in different areas, and then it's going up. And then I ran just projected annualized data for this year, which is showing that the elder benefit specialist area has decreased a little, but that's because we had one staff who was out for a few months on a medical leave, so the numbers are going to be a little bit different. So, like I said before, in 2023, the data demonstrated that every dollar invested in an ADRC saves taxpayers $3.88. I think that's pretty profound. So that number is captured from reduced emergency room visits and reduced inpatient hospitalizations. The funding, unfortunately, for ADRCs has remained stagnant since 2008. We've been operating with the same amount of funding. Last year, with the biennium budget, we were able to, throughout the state, they were able to gain approval for a $5 million increase statewide in the biennium budget. But with change in funding amounts comes changes with formulas and how that money gets dispersed. And unfortunately, that led to our county losing money, which is really hard to believe. But fortunately, the state is holding every county they're holding us harmless on that, and they're going to cover the difference. But it's just with the way that they calculated the demographics and the populations, we didn't score as many points as some of our rural partners who obviously have different challenges that they're facing in a rural community. I mentioned a little earlier on that we are required to do an aging plan update every 3 years as part of our Older Americans Act requirements. And so with that process, we're actually in the process of developing that for 2025 through 2027 right now. And so we recently just surveyed our population and our residents in our community around all of the things related to aging in St. Croix County. And as a result of that, there's the 4 highest areas that individuals reported the highest needs. The top 3 include social isolation and loneliness. And I just want to make mention of that because that's obviously something that impacts everybody. It's countywide, it's statewide, it's nationwide. You're hearing about it on the news. It's an initiative that the state is really wanting counties to work on and ADRCs to focus on. But one of our programs that works to reduce social isolation and loneliness is our congregate nutrition. But as we reduce those types of challenges, our costs go up. So just know that we're mindful of that. We know that there's costs involved with that, but we're trying really hard to balance out the needs of the people and also being fiscally responsible as much as well too. Another way, we're always looking to try to create efficiencies and create opportunities to save taxpayer dollars. One example of that is the work that we do with volunteers. So in 2023, we had 233 volunteers who donated over 14,000 hours of their time to work in the ADRC and to serve our people. That equates to about $442,000 in tax savings. So that's pretty amazing. It's just, even during COVID, we had volunteers who just continued to step up to the plate to deliver meals. And it's pretty remarkable the amount of time that goes into their, that they spend into other people's lives. We also just recently transitioned our ADRC newsletter to a new service provider, a new vendor, and that's estimated to save us at least $35,000 just in the newsletter costs, indirect staffing costs, mileage, transportation, postage. We've reduced a lot of our mailing distributions and things, and we're just trying to really think about how can we do what we're doing now differently to create some of these efficiencies. So that's exciting too. I have a copy of the new newsletter for anyone who wants one before you leave. Yeah, that's kind of it. So this main slide here is just basically how to make a referral to the ADRC. We have a general number. Like I said, we have somebody who answers the phone at all the time during business hours. And if you have questions or if you need anything, that's my contact information too. You're more than welcome to reach out anytime. Does anyone have any questions right now? I know it's a lot of information.
Go ahead, Bob.
Thank you, Kristen. I think you did a nice job defining all of that in a few minutes. I just wanted to mention before questions that every year when we look at our budget for HHS, I try and look at the priorities that we have, the things that are really on the horizon that we think are going to be problematic going forward in terms of trends and demands on our service areas. So all of our service areas are taxed, so to speak, in terms of demand. But in looking at the demographics for Wisconsin, for the country really, of the baby boomer generation aging out, and these kinds of services that the ADRC provides as being necessary and in need of development, I wanted to mention that we looked at this area, the ADRC, and are asking in the 25 budget, we're requesting 2 new positions in the budget. Now we understand, and that is, I'll let Kristen mention a little bit about both of them, but one is an ADRC resource specialist and the other is a disability benefits specialist. I think speaking to the data that she showed, the need is pretty evident. But we understand the budget pressures that the county faces with health insurance going up and all of the other demands that are present in the county. But in looking at, from our point of view, of populations going forward that are most likely to place an increasing demand on us without any funding from the state that correlates with that, we need to help Kristen a little bit here, because no matter how efficient she is, there's a point at which we can't meet the demands of the public. So that's the reason we've asked for these two positions. We always put a lot of thought into this because we understand, again, the budget pressures that the board is faced with and Ken is faced with. So I don't know. Those two positions are the ones that I think, and an FTE increase for the supervisor. Yeah, since I submitted these two requests, that's changed a little bit, so could you, not too much, but a little bit. Could you speak to that though, Kristen?
Yeah, I sure can, and Faye, certainly jump in here if you remember exactly where we were at with that, but basically we were estimating about an $88,000 cost to tax levy for both those positions. One would be considered a resource specialist, so we were looking at trying to hire someone who was not quite at the social work level or the ADRC level, but someone to help kind of manage our referrals and manage the triage of all of the cases and the information and referrals. So we're thinking that would be a cost-effective way to do that. That's a position that we could bill for Medicaid reimbursement. So based on the total cost of that position, we would estimate that we'd be getting roughly 50% in federal funding to cover that. Right, Faye? I could see you thinking numbers. Yeah. And then the other position is the disability benefits specialist position. So that's the area that I was speaking about with the individuals that are served from 18 to 59 who are applying for disability, and the flow of those cases and the demand for their services is really high. And like I said, the program support attorneys have been on me about their caseloads, and they're at 200 right now, which is extremely high for them, and it would be really helpful to have some type of help to at least offset some of that. It's hard to project what the future is going to bring in that world as well. But I will just make mention that, you know, the ADRCs serve the fastest growing demographic. So the aging population is growing at unprecedented rates. I mean, it's expected to rise by 21% just before, you know, between 2020 and 2030. So we have to do something to try to manage that, because it just when you don't help them, when you don't help people, it just spills into another system, right? So we're trying to create some type of opportunity to help offset some of those other systems. It's better all the way around. Yeah, that one was rough. What were we thinking, Faye? I'm so sorry, I didn't prepare this.
And that one, so on the ADRC on the match side, when it's an MA application, we get a 50% match. If it's a long-term care, it's a 75% match, but it really goes down to these time studies and how much is split between it. And if it gets really fuzzy when we're adding new positions of, okay, how much of the current staff, if their percentages will change from their time study. So initially we were thinking 50%. I think it'll be slightly less than 50% because their caseloads might be that, but someone else's caseloads might drop to less MA match now.
Yes. I think we initially were expecting that to be about a $50,000 out-of-pocket expense, but it sounds like it'll be a little bit more. I'm always a little more optimistic with my number calculations than Faye is, so she's much more realistic.
And then Ken gets more conservative yet. So the resource specialist and the disability benefit specialist, which line items or bar lines do they address?
So the resource specialist would help address the blue line, the top line, just with the flow of the intakes and the referrals to the ADRC. And the disability benefit specialist is the orangish red area. So that's the area that just continues to grow there. And like I said, this is calls to their division, but that doesn't represent the number of open cases that they're managing on top of those calls.
Yeah. The intake, it's such a large increase over the last 2 years. Is there any reasoning that you can figure out behind that? I mean, it's such a huge increase after, 4 years of fairly steady.
We took a lot of calls from the public health unwinding, and we've had a lot of changes post-COVID, so it could be related to that. It could be data tracking. We may be capturing data differently in the last few years too, but yeah, exactly, just in 2 years. Yeah, it's hard to say. I wouldn't be able to pinpoint exactly what it is, but anecdotally, I think it's just the volume is just higher.
Any other questions? Go ahead.
I just want to make a comment. The services provided by the ADRC are so important to the health and wellness of our communities. And as we face this growth in our elderly population, and particularly in our rural setting, it's terrifying. How are we going to care for these people? And this kind of upstream work is so important. It is where we need to focus so that we can prevent that from coming downstream into the resources that we also don't have. So thank you for what you're doing, and I just want to express my support for that.
Thank you.
So this is just intake. To Ken's point, the disability specialist would still be interfacing with people past the intake stage. So it's not like a simple call and then it's all solved. You're managing a caseload.
Correct. Yeah, that's their area where they're managing those open cases at the time they're applying for disability. You're managing that through that whole process, which is quite lengthy. I mean, sometimes over a year. Yeah.
So I think that might be good data to share too when we're talking about trying to make the case for the
That
positions.
was the caseload of the 150 last year, now it's 200 cases per this year.
Yes, correct.
So you presented all this data, and now you've got a crystal ball and a magic wand. What would you do? What would be the magic in all this that we could make it all better?
It's hard to say. I think the needs continue to change and continue to evolve, and I think it's really important that we stay on top of that and stay ahead of it and try to stay as proactive as possible. I mean, sometimes more services isn't what is needed. You don't want to just throw mud at the wall and hope for the best. So we're always trying to be as creative and as smart about it as possible, but I do think that, refining just our whole intake flow will help manage just kind of the service demand in that area. I think that's a big area that could really just change just in terms of how we creatively think about the referral process. This year alone, we added another position to that division, and I've been saying out loud to them since we started this process is, I don't want to just add another position and keep doing things the same way, because it doesn't help. We need to try to think about how to do it differently. And so we're always working on that and trying to think of things, but crystal ball, I don't know if there is one. I'd love to say it's more funding, but that doesn't always, equate to results in the way we want them either. So we'll keep at it.
Thank you. Any other questions? Thank you very much. Thanks for all the information. Next item, agenda is legislative update. Is that you, Bob?
Yeah, thank you, Chair. Yeah. Dr. Finley's point to moving upstream of high-cost services is a theme that we've been pursuing in the last few years to try and move what we do upstream to prevent those high-cost deep-end services like hospital care, emergency services of any kind, crisis care. So you always want to intervene a little earlier in that process to try and prevent those deep-end costs. Unfortunately, the system that funds us hasn't switched to an early intervention model. It remains an acute care model. So as Dr. Finley and Supervisor Lynn know, as medical professionals, our healthcare system has been designed to treat people after they become sick, which it results in poor outcomes usually, or poorer outcomes and more cost. So we continually, to Kristen's point, we continually can't just throw money at deep end costs and hope for better results. It doesn't make any sense. So in the legislative update, what you see in the first part there is the Wisconsin Counties Association legislative agenda for mental health, which they made a priority last year in the last session with some good results. But where we remain, where we continue to struggle in human services is around crisis care and those early intervention or upstream solutions for people with serious and persistent mental illness who, with the right support, can remain in their homes or their communities. Without it, often end up in hospitals or high-cost environments. And that goes for people with addiction as well, and goes for anyone who's struggling with behavioral health conditions. So we used our ARPA funding that we got from the board back in 21, I think, to develop some of these upstream positions, these co-responder positions, the peer support specialists, community case managers, and assistance to recovery housing, and the withdrawal management project at Western Wisconsin Health. These were all intended to treat people before they got very sick and before they ended up in these high-cost environments like Winnebago or a hospital, emergency department. So that's sort of what the WCA is asking for here. They're asking for additional money, but it's to cover the federal or the state share of Medicaid that the counties currently pay, and to help with the uninsured costs that we incur because we have to pay for those folks without insurance to go to Winnebago or to wherever. Well, Medicaid doesn't cover Winnebago. So the Wisconsin Counties Association legislative agenda focuses on CSP, community support programs that treat those with serious and persistent mental illness in the community setting, so they hopefully can remain in their communities. And they focus on crisis services that are terribly underfunded that we end up, or taxpayers end up paying for. That is kind of a continuation of the last session where these things were asked for. There was some money given to help cover the state share, but it was really not enough to impact the rising demands and the acuity of the people that we're seeing. So our costs continue to go up in purchase services, as you can see from our budget. I'll just move through this real quick because the other two items kind of tie into this. And then I'll see if you have any questions. In the last session, there were two acts that were passed into law. One was Act 249, which has to do with crisis. I have to get the title right. They change the names of these things all the time. But it's, what is it? Crisis, crisis stabilization, observation. There it is. Crisis urgent care and observation facilities. This was money that the state, or that the legislature approved for the state to use $10 million to develop 3 regional crisis observation facilities. So prioritizing the western region because we have such a desert here of short-term crisis intervention facilities. We don't have any around here. But what that act does is it requires DHS to write rule language, promulgate rule language around this service area, which would be brand new. And once that rule language is developed, then they would put out an RFP for counties to apply for, or it might be nonprofits as well. The challenge here is that they have to write this rule language to write this 16,000 pages of regulations that we would have to follow, or somebody would have to follow to open one of these facilities. The other challenge with it is that the state has to get federal approval for Medicaid to cover this service going forward. So it wouldn't, otherwise it would just be a grant that paid for the startup and then everybody would run out of money. So there's a component to this that goes into the next act that I put into your packets. But the idea behind this is to stabilize folks who need maybe a short-term length of stay in a residential setting, 24/7 facility, to treat their mental health and their addiction simultaneously, and to help then connect them to services in the community that would support them beyond that, so that they don't end up going to the hospital, and they don't end up ending up in jail and other kinds of unfavorable outcomes. I was, I think I was invited to be on an advisory committee to help write the rule language. The email wasn't very clear. Myself and Chief Young from River Falls both got the same email, and we both had the same reaction to it, so we both said we'd do it, and haven't heard back yet. But that would be the next step, is to write the rule language. And yeah, well, I would like to be on that. I've done similar things, so it would be helpful to have a voice in that process. Now, it's going to be dependent, though, on the next act, which requires DHS to apply for a federal waiver. It's called an 1115 waiver that allows Medicaid spending in projects like this, and also in IMD settings, institutions for mental disease. And I don't want to get into the weeds, but IMD settings are typically mental health or addiction treatment facilities with more than 15 beds, which are not eligible for Medicaid payment without a waiver of some kind, which limits us to where we can send people and have Medicaid cover their stay, right? Winnebago is an IMD, an institution for mental disease. So this Act 177 requires the state to apply for this waiver through the Centers for Medicare and Medicaid, get that waiver approved, and probably do an amendment to their state plan. So this would then allow us to recover some Medicaid reimbursement for people that end up in Winnebago or some other IMD setting, and would help to reduce our costs, which are typically tax levy. A side note to that is there was a mental health addiction and mental health addiction equity. The hell is that? It's a parity law that's supposed to require insurance companies to pay the same equitable rate for behavioral health care as they do for physical health care. So the two, behavioral health care and physical health care, should be in parity in terms of how they're reimbursed. That hasn't been enforced. It's a federal law, but it hasn't been enforced really anywhere in the country. It's because insurance companies struggle with, how do I equate a particular treatment to this rate versus I broke my arm and I need a cast. It's not as clear, right? So nobody's acted on it. It's really up to the state attorneys general to take action to make this happen. I say that because it currently, private health insurance doesn't pay for a lot of these behavioral health conditions or treatment needs, or they pay a portion of it, or their deductibles are so high that it doesn't matter for people. So these two acts attempt to provide a short-term residential setting for people in behavioral health crisis, to stabilize them and move them back into their community and avoid hospital levels of care or jail or some other high-cost environment. And the Act 177 seeks to find Medicaid reimbursement to fund projects like that, or to reimburse counties, for instance, for placing people in IMD settings, so the cost doesn't totally fall on the county human service program. Both of these things, and I know, Chair Telejohn, we passed, or you passed a resolution in this committee, and then the board passed a resolution to emphasize to DHS that they need to take some action on items like this, because we're in a situation where we have very few places to refer people, and the cost is going up and up and up. So these two acts will probably take at least a year or two, I would say two, before we see them come to fruition, if they do. The real challenge is getting CMS to agree to the state's plan for how they're going to spend their Medicaid dollars. They don't get additional Medicaid dollars. They have to redistribute what they have. to cover IMD settings and things of that nature. So it's a state plan amendment combined with this 1115 waiver request. And that takes time because CMS is not always the quickest to respond. They have 90 days to respond, and they wait till day 89, and then they respond with questions, and then the clock starts over. So it can take a while. But I did go through this in Minnesota. I was a part of the effort to get an 1115 waiver to have Medicaid cover behavioral health costs, and we were successful, but it took a lot of effort and the state's commitment to doing that. But it did lower rates of hospitalization and helped law enforcement in the jail with respect to where they could take people and as an option to taking people to jail, they could take them to a place where they could actually get help. So in the long run, it pays off, and we have to nudge the system away from acute care and away from deep end costs and poor outcomes to an earlier point in intervention where we can have an actual impact on that person. And much like what Kristen was talking about, helping people stay in their homes, helping them stay in their communities, and they do better usually in those situations. This applies to not just the ADRC or behavioral health, it applies to children's services and efforts there to do the same thing, to keep families together and to keep kids in the home, if possible, if it's safe and it's possible. So I wanted you to have these two pieces of legislation from the last session so you didn't have to look for them, and kind of keep those in mind going forward. And then the WCA's legislative agenda will be coming forward in the next session. We'll also be meeting with lawmakers to advocate for things specific to St. Croix County that we think would be helpful and beneficial and a different way, as Kristen said, a different way to spend money, not doing the same thing over and over again and hoping for something better to come out of it. So that's our idea going forward. We'll put together a legislative agenda of our own that we'll show you when we get a little further along in the session. I want to see what the other associations come up with. This is one example, but we have several lobbying groups and associations for different areas of HHS, and we try and put all those together into one concise document so it's not 10,000 pages because they don't read them. So. But anyway, I'll stop and I'll just see if you have any questions about any of this.
Well, for doing the rule writing for Act 249, they're not waiting for Act 177.
No, but it says in there, if you read it, it says that it's contingent on funding, Medicaid funding through a state plan amendment. So if they don't get that funding, good luck after your startup money runs out. That's the way I read it anyway, and that's probably the way it is.
Is there any other questions? Well, congratulations to being on the rule writing committee.
Maybe.
No, you are. I interpret it that way. Thank you, Bob. Request for future agenda items. Anybody have any great ideas? Poor ideas? No? I brought up last time about having a meeting at Health and Human Services. Would people be able to meet at, say, 8 o'clock in the morning when we have employees at the health center? Would that work?
Would depend on the day for me.
Is there a good day, bad day?
Today's a bad day. I mean, Wednesdays are bad for me, so.
Okay. Well,
So would it be a tour or?
yeah, it's kind of a walkthrough, see who's there, what the departments are.
This would be one of your regular meetings you're
It
looking at
would take
doing?
place in place of a regular meeting, yeah.
Okay.
Would it be possible to meet at 5 or
Well,
4:30
there's
or?
no
Or you guys
point.
are all gone?
Yeah, that's
the day.
my whole point.
Yeah.
I want to see them working.
Well, I could offer a tour maybe at 4. Would that work? And our staff would be there. And you could see the building and then just move into the meeting.
we'll take that under advisement, maybe. Right, thank you. Any other announcements? No? Well, go ahead.
I just wanted to remind you on the county website, there's a community health assessment that we're asking everyone in the county to take, but it helps us, our public health department, get feedback on what the top health priorities are for residents of St. Croix County. It doesn't take too long to do the assessment, and it's on our website. It says community health assessment on there. If you have a chance to spread that around, that word, and help us get as many responses as we can, it gives us a better idea of what the health priorities are of our residents.
Any other?
I got an idea, but would we be able to have our HHS meeting at that, I mean, just a regular meeting there? Is it set up for cameras or no? No, so that's why we gotta have it here, so, okay.
Kathy's got an iPhone.
There is a room where we have ADRC meetings though, or the council. That would work, right?
Yeah, those aren't broadcast, so that's what Mike was
Oh,
asking about.
right, okay.
So it wouldn't be broadcast. So I would say a lighter agenda meeting. Your August one would be fine. September, you'll be doing budget review. You probably want that one publicly visible. So it just maybe depends on what the agenda looks like.
Yeah, I mean, obviously, yeah, if we have something, but yeah, we'll work it out, maybe. Okay, our next meeting is August 21st. We don't know where yet. Thank you, everyone. Meeting is adjourned.